Welcome to another lifelong nursing video. This video focuses on Pulmonary CCRN Review Part 2. I'm Brent, and let's get started. These are just a reminder of the pulmonary testable areas on the CCRN exam. So if you haven't watched Part 1, please be sure to go back and watch Part 1 as we cover a portion of these in the first video. So let's begin with obstructive lung diseases. These are diseases or disorders of the lung that trap air and gas within the lungs and over time causes difficulty getting air out. And this gives the patient enlarged lungs and chest, otherwise known as barrel chest. These are diseases such as COPD, emphysema, asthma, bronchitis, and as you can see on this diagram here, the amount of volume that can be expired over the amount of time is less in obstructive. The first number here, the FEV1, the forced expiration volume, under 1 second, is a lot lower within that first second, so you're unable to, in obstructive diseases, expire the same amount of air as you normally would in that first 1 second. So it takes a longer amount of the air, most of your air to come out. So let's start with bronchitis. It's defined as an inflammatory response to an irritant in the lungs or airways. This causes mucosal edema and bronchospasms within the small and large airways, not just the alveoli clusters. Also, it causes congestion within the lungs and vasodilation. It's always acute unless the patient has had bronchitis for greater than 3 months each year for the past 2 years or longer. Moving on to COPD. These are just some short points here. It starts as an inflammatory response to an irritant in the lungs or airways, just like bronchitis. However, smoking is the #1 cause. It can also be caused from alpha-1 antitrypsin disease, which is genetic. It can be caused from occupational exposure. And just as with bronchitis, it causes mucosal edema and bronchospasms within the small and large airways, not just the alveoli clusters. It also causes congestion within the lungs and vasodilation, and over time causes tissue injury, leading to decreased surfactant and bronchiolar and alveolar collapse. This leads to obstruction in the air trapping that we've talked about with obstruction disease. This bronchiolar and alveolar collapse leads to obstruction in air trapping, which causes the patient's barrel chest. So from the alveoli that are collapsed, this enlarges the air sacs, leading to a loss of elastic fibers. This leads to obstruction in air trapping. So if you have air trapped in the alveolar sac and it collapses, the pathway that the airway follows to get out when you're expiring, if that airway collapses, that air is trapped. So when you inhale again, you're essentially opening that airway again, and then you're trapping more air, which causes that alveolar cluster to enlarge, which leads to increasing and enlarging the air sacs, which leads to the loss of elastic fibers, and subsequently causing alveoli to fuse together, decreasing surface area, which also leads to less gas exchange. Continuing on, after these enlarging alveolar sacs, the increased pressure in the chest, it leads to pulmonary hypertension, hypoxia, and increased ventricular afterload on the right side of the heart. So this leads to right-sided heart failure. The clinical presentation of COPD typically is dyspnea, arrest, and exertion, tachypnea with small tidal volumes, malnutrition and or muscle wasting, diminished breath sounds, often most commonly in the bases of the lungs, increased and anterior-posterior diameter of the chest, again, this is barrel chest, and on the chest x-ray it can reveal a flattened diaphragm. Treatment options for COPD include ultimately treating the cause of admission. So you're not going to cure COPD, you're going to try and treat what caused the exacerbation for them to come into the hospital. So often in these cases, we're going to apply oxygen, but you want to be cautious because in COPD, their drive to breathe is opposite of ours. So you want to be cautious as this air trapping occurs. Often these people retain CO2. So the more oxygen you give them, the more CO2 they retain. And then ultimately that can lead to a decrease in level of consciousness. So you want to be careful about oxygen administration. Often people with severe COPD, their O2 saturations are commonly in the high 80s, low 90s, even at rest. You want to get removal of secretions. That's them coughing that up. That's you NT suctioning them or suctioning them on the ventilator if they're intubated. You want to provide hydration for the patient, as these people are going to have increased work of breathing and going to need more fluid requirements, and you're going to want to humidify the O2 as not to cause mucus plugs and subsequent atelectasis or lung collapse within these patients. Pharmacologically, we want to give them antibiotics if required, steroids, inhaled steroids, bronchodilators such as beta-2 agonists, that's your albuterol or levobuterol, and mucolytics. For nutrition, we can provide high-calorie, low-carbohydrate foods. This will help provide the energy needed to maintain their work of breathing. So we're going to move on to status asthmaticus. Status asthmaticus is a hyperreactive airway disease that causes severe airway narrowing and typically is not relieved with therapies such as beta-2 agonists and mucolytics. This leads to bronchospasms, increased mucus production, and causes severe airway trapping where there's often no airway movement at all. So if you're assessing your patient that has status asthmaticus and you don't hear any airway sounds at all, you first think, okay, do they have a collapsed lung? That's possible. Or are they just so locked down in their asthma that they're not able to move any air whatsoever? That's a very, very serious sign and should be reported immediately. This also causes an increase in intrathoracic pressures that end up decreasing the venous return to the heart and subsequently increasing the right ventricular afterload due to that pulmonary hypertension. So the presentation of status asthmaticus, you're going to have cough, chest tightness, tachycardia, tachypnea, anxiety, often a lot of anxiety as these patients aren't able to breathe, aren't able to speak just in but one-word sentences. Often they aren't able to speak at all because they're focusing on their work of breathing. And you're going to have lower level of consciousness, which is a late sign, and a lot of accessory muscle use. Treatment for status asthmaticus is bronchodilators, often continuous, anticholinergics, corticosteroids, hydration. Again, for their increased work of breathing, they're going to need a lot more fluid requirements. And using the ventilator, keep in mind that you're going to use lower tidal volumes in the ventilator because of the air trapping and because of their airway constrictions. You're not going to be able to get enough or get as much air into their lungs as a person without status asthmaticus could. So you're going to want to increase their expiration time to reduce that amount of air trapping. So that's obstructive diseases. We're going to move into restrictive lung diseases. These are diseases or disorders that include, but are not limited to, acute lung injury, ARDS, infections such as pneumonia, sarcoidosis, and atelectasis. So these are diseases that cause the restriction of inhalation, essentially, in your lung. These are diseases that restrict the lungs from expanding during inhalation, causing decreased lung compliance and lung volumes to be decreased. So you're not going to have as much lung compliance, and you're not going to be able to have as much lung volume due to that restriction. Just for the CCRN test, we'll go over acute lung injury, ARDS, pulmonary fibrosis, and pneumonia. These are all signs or all examples of restrictive lung diseases. So restrictive lung diseases, we're going to start with acute lung injury, or ARDS. So this is the first step in progressive acute respiratory disease syndrome. So you're going to have, this is like a pulmonary contusion, direct or indirect injury, which causes significant amount of inflammatory response, ultimately leading to an increased capillary permeability, which causes edema and subsequently ARDS. So if you have at the capillary level inflammation and all these cytokines that migrate to these areas, which increases your capillary permeability, you're going to have capillary leak of blood, lymph fluid, serous fluid, that sort of thing, causing pulmonary edema and ARDS. So ARDS has 3 stages: exudative, which is the first 0 to 4 days, proliferative, 3 to 10 days, and fibrotic, 7 to 14 days. Now, to be considered ARDS, the following must be documented: a chest x-ray that shows bilateral opacities which does not have an etiology of effusion, or lobular or lung collapse or nodules. So you're ruling out lung cancer, you're ruling out a collapsed lung, you're ruling out severe atelectasis that has caused all of this. Must be within 1 week of new or worsening respiratory symptoms or known clinical insult to the lungs. So that's the acute portion of this. And then you're going to have respiratory failure that is not due to cardiac function or fluid overload. So essentially you're ruling out congestive heart failure, left ventricular heart failure. You're ruling out systolic heart failure, any other term that you want to use. This is respiratory failure from a non-cardiogenic standpoint, a non-lung carcinoma, or things like that. So you're going to have it. This is the only reason that this could be ARDS. So it could be mild, moderate, or severe. So if we go back, you can see it has 3 stages, but it's classified differently. So 3 stages are exudative, proliferative, fibrotic, and then it can be classified as mild, moderate, or severe. So you can have mild exudative, mild proliferative, moderate proliferative, severe fibrotic, that sort of thing. To determine how severe, you must obtain a PaO2 FiO2 ratio by using an arterial blood gas. So, for example, you obtain an ABG for suspected ARDS, and the PaO2 level on the ABG is 90, while the patient is on 45% FiO2. So 90 divided by 45, or 90 divided by 0.45, this is a percentage, equals 200. That's the ratio. So under this classification system, mild, the ratio is between 200 and 300 millimeters of mercury. So this is with PEEP or CPAP. So moving on to moderate, this ratio is going to be between 100 and 200 millimeters of mercury, and the patient often is going to have a PEEP greater than 5. Severe, the ratio is going to be less than 100, and the patient's going to require greater than 5 of PEEP on the ventilator. And so the treatment for ARDS, whether mild, moderate, or severe, is going to be essentially the same thing. You're going to want to make sure you have mechanical ventilation. You want to prevent infection with the VAP bundles, raising the head at least 30 degrees, 35 degrees, performing oral care, doing trach care if the patient has a trach, and then positioning the patient upright and treating the underlying cause. So that's ARDS in a nutshell. You basically need to understand the timing on the stages, which is exudative, again, 0 to 4, proliferative, 3 to 10 days, and then fibrotic stage, 7 to 14 days. Often when patients hit the fibrotic stage, often it is very much a poor prognosis, and so you must hit this early with high amounts of PEEP, high amounts of mechanical ventilation, and positioning the patient upright, and really narrowing down and optimizing your therapy to ensure their survival. So moving on to pulmonary fibrosis, this is another restrictive lung disease, so it's going to restrict the patient's ability to inhale and expand their lungs due to fibrosis. So this is an interstitial lung disease that causes scarring, in which the scarring can become so severe the patient goes into respiratory failure. The scar tissue of the lungs not only reduces the elasticity of the lungs, but causes a decrease in expansion of the lung and also reduces gas exchange, as no gas exchange can occur through scar tissue. Pulmonary fibrosis can be primary in nature, which is inherited, or idiopathic, so it's saying it just showed up, there was no identifiable cause, or secondary, it's due to radiation, medications, medical conditions, or occupational hazards, so things like that. Treatment for this includes supportive care. You're going to ventilate and oxygenate the patient, give them medications such as bronchodilators, anti-anxiety medications, oxygen, and rehabilitation to get their body to the best of their ability for living with pulmonary fibrosis. So that's just a touch on pulmonary fibrosis as a restrictive lung disease. We're going to move on to pneumonia. Pneumonia is caused by an infection that leads to alveolar consolidation within the lungs. Sometimes it may be hard to distinguish bronchitis with pneumonia, therefore chest x-rays are important to help rule out one or the other. Pneumonia causes an inflammatory response within the lung parenchyma and subsequent exudate and phlegm production. It's most commonly from a bacterial infection, but it can be viral, fungal, from aspiration, and even parasites within the body. There's 3 classifications in pneumonia. So you have community-acquired pneumonia, healthcare-acquired pneumonia, or ventilator-associated pneumonia. From a real-world standpoint, you're going to treat community-acquired pneumonia with slightly different antibiotics than healthcare-acquired pneumonia, just for the sheer statistics on that community-acquired pneumonia often is a different organism than healthcare-acquired pneumonia, because in healthcare-acquired pneumonia, you often have the resistant bugs such as VRE, CRE, MRSA. You're going to use generally the stronger antibiotics for healthcare-acquired pneumonia, at least until your antibiotic cultures come back. So just like I said, CAP is different bacterially, typically, than HCAP, so therefore bacterial antibiotic treatment may differ. So risk factors for pneumonia include age, smoking, chronic illness, malnutrition, artificial airways such as the ventilator, atelectasis, aspiration, immobility, immunocompromised patients, a decreased gag reflex or cough reflex, and multi-organ system dysfunction. Some of the signs and symptoms of pneumonia include dehydration, tachycardia, chest pain, chills, fever, malaise, productive cough, and confusion, which often presents in the elderly. Treatment for pneumonia in general are chest x-rays, sputum cultures if possible, and arterial blood gases. Antibiotics, antivirals, or antifungals, depending on the culture. Within the hospital, you're only going to start prophylactically the patient on antibiotics, generally. Positioning the patient with a good lung down for increased perfusion of the good lung related to gravity and its effects on blood to allow for better gas exchange throughout the good lung. You're going to want to remove secretions through suctioning or bronchoscopies. You're going to want to mobilize the patient if you're able. Just because they're on the ventilator does not mean they have to lay in the bed, even if they're intubated. I've mobilized plenty of intubated patients. And given fluids to hydrate, fever control, and providing that patient with adequate nutrition. In chest trauma, you're going to want to learn the mechanism of injury and location of injury. So if you have injury to the chest or chest wall, you're going to often have pulmonary contusion, pneumothorax, hemothorax, and often lacerations. If it's just the chest, meaning the anterior upper portion of the chest where the sternum is, you can have cardiac rupture, cardiac tamponade, cardiac contusion, damage to the great vessels that can cause aortic dissection or hemorrhaging. All right, so that's just understand that. So in chest trauma, you want to if you want to treat the location and the underlying organs that could potentially be damaged as well. So moving on to air leak syndromes, you're going to have this in this first example, pneumothorax. This is caused by a tear in the pleura of the lung, which can be caused from thoracic trauma, barotrauma, so given too much tidal volume or too much pressure through mechanical ventilation, or iatrogenic, which is caused by particular pathologies within the body. So it'll start as air leaking from the lungs into the chest, causing a lung collapse. Several classifications include the pneumothorax or simple, tension pneumothorax, hemothorax, and a pneumomediastinum. So some of the signs of pneumothorax are, of course, respiratory distress, tachycardia, hypotension, diminished breath sounds on the side that the pneumothorax has occurred. Often it can be both sides bilaterally. Visualization on the x-ray, hypoxemia as well. So tension pneumothorax is one of the ones you can see without a chest x-ray. Sometimes you can see tracheal deviation and jugular venous distension due to the buildup of pressure from that tension pneumothorax, and that's essentially a buildup of pressure from the air leaking into the chest wall essentially filling up with air, creating intrathoracic pressure and causing decreased lung compliance, and subsequently causing the tracheal deviation and JVD. So as you can see here, you have the interstitial lung markings on a normal lung on the left side, and then on the right side, you're going to notice an absence of lung markings on the patient's right side, and that's due to this collapsed lung here. So this is the line of the parenchyma of the lung that is collapsed, and notice it's on the right side of that, there's absolutely no lung markings. You have essentially a hollow chest there. And then on the left side of that line, from the patient's perspective, you're going to have the lung tissue that's there and that's radiopaque, so you can make out the lung tissue. So treatment for the pneumothorax is a needle decompression with chest tube placement. The chest tube is inserted high for pneumothorax, and that's so the air can leak out through the high portion, because air is going to travel against gravity because it's buoyant. And then you put it in low for hemothorax. So the blood does not travel high, it travels low because of gravity. So that's pretty self-explanatory there. And then you have O2 administration and intubation if it's required. While placing the chest tube and an air embolism is suspected, you can place the patient in Trendelenburg on the left side to trap air into the right ventricle. Make sure there are just some care for the chest tube patients. Make sure there's no dependent loops in the chest tubing. And for the CCRN test, no milking or stripping the chest tube. This is just for the CCRN test. Often you'll see physicians or advanced practice professionals milking or stripping chest tubes to remove clots, that sort of nature, get rid of all the fibrotic tissue inside that chest tube. But for the CCRN test, do not milk or strip chest tubes. So let's move on to carbon monoxide poisoning. So let's give an example here. A 50-year-old woman who lives at home with her husband was upstairs in her home while her husband went to the store, and all of a sudden she heard the fire smoke alarms ringing throughout the house. She then attempts to go downstairs and investigate. However, the fire was already spread throughout most of the downstairs. Risking her life, she escaped her home, but not before inhaling a lot of smoke and suffering carbon monoxide poisoning. Outside, firefighters were already on the scene setting up, and the woman begins to immediately feel short of breath, becomes dizzy, and faints. At a cellular level, why does she experience these symptoms? That's because your hemoglobin in your blood carries both oxygen and CO2 within the red blood cell. That's the binding site for those two gases. When someone suffers carbon monoxide poisoning, the hemoglobin holds on stronger to carbon monoxide. It has a greater affinity for that carbon monoxide than it does CO2 or O2. Therefore, does not allow that hemoglobin molecule to carry carbon dioxide or oxygen. So essentially the body is unable to rid itself of CO2 and is unable to gain O2. The more carbon monoxide that is inhaled, the less carbon dioxide and oxygen can be exchanged and utilized. So the treatment for this is 100% oxygen administration, hyperbaric if possible, and continue O2 administration until your carboxyhemoglobin level is less than 10%. So just understand, in carbon monoxide poisoning, you cannot get an accurate reading of the O2 saturations by using an O2 monitor. So that's why you're going to be drawing a carboxyhemoglobin level, and that's going to say how much carbon monoxide is in the body. So that will essentially give you your effective O2 saturation. So if you draw carboxyhemoglobin level and it's 20% in the body, then physically your body can only have 80% oxygen saturation due to that carbon monoxide. So you want to continue O2 administration until that level is less than 10%, so you know that the body is capable of carrying O2 saturation of greater than 90%. That's it of this video. Thank you for watching part 2. Please be sure to watch part 1 of the pulmonary concept if you haven't already. As always, please subscribe and visit lifelongnursing.com for more great and free content. Remember, learn everything.